Good afternoon, everyone. It is 2:30. We've got a pretty hefty agenda, so we want to make sure that we get started on time. What we'll do is start the way we normally do with introductions.
Good afternoon. I am Christine Smith, Clerk to the Board.
Good afternoon. I am Marlissa Easton, Deputy Clerk to the Board.
Good afternoon. I'm Susan Rodriguez McDowell, and I have the honor of being elected by the people of District 6.
Good afternoon. I'm Laura Meyer, and I represent District 5.
Good afternoon, George Dunlap, elected by the people of District 3.
Good afternoon, Lee Altman, County Commissioner serving at large, and I have the privilege of serving as Vice Chair.
Good afternoon and welcome, everyone. My name is Mark Jarrell. I've been elected by the people of District 4. Also have the honor of serving as Chair of the Board.
Good afternoon. My name is Vilma D. Leake, and I represent the most powerful district in the county. Welcome. Good to see you.
Good afternoon and welcome. My name is Arthur Griffin. I have the pleasure of serving as County Commissioner at large.
Good afternoon. I am Mecklenburg County Commissioner Elaine Powell, Chair of the Environmental Stewardship Committee and representative for North Mecklenburg. Thank you. Welcome.
Good afternoon and welcome, everyone. My name is Yvette Townsend Ingram. I have the pleasure of being re-elected as your Board of County Commissioner at large.
Good afternoon, Tyrone Wade, County Attorney.
Good afternoon. Welcome. Mike Bryan, Mecklenburg County Manager.
And I know we have a lot of staff in the room. We will limit introductions to the executive team, please.
Dr. Kim Campbell, Deputy County Manager.
Michelle Attreed, Deputy County Manager.
Derek Ramos, Deputy County Manager and Chief of Staff.
Okay. Before we go to the Pledge of Allegiance, what I would like to do is recognize former City Councilman Al Austin. Thank you for joining us. If you'll join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, before I turn it over to the manager, there are two items that I want to lift up. The first one is just something that we do for those of you that are just joining us. I'd like to, and we as a board like to make sure that everyone is acclimated with our mission and our vision. And our mission is to serve Mecklenburg County residents by helping improve their lives and community. Our vision is Mecklenburg County will be a community of pride and choice for people to live, learn, work, and recreate. I also want to lift up our FY 26 and 27 board budget priorities. They are as follows: economic development, education, environmental stewardship, health equity and wellness, services for seniors, workforce development, and reducing racial disparities. So we like to think that it's important to make sure that we level set with the community or anyone that watches our meetings so that you understand exactly what guides our conversation, what guides our thoughts, and what guides our actions. So I hope that will provide a level set. And before I turn it over to the manager, I know we are excited about today's agenda. Thank you, Mr. Manager. I know one is a follow-up from the retreat. But before we do that, we've got some board business to take care of. And what I'd like to just lift up as a reminder to all of my colleagues is that a lot of our requests that have been coming out with respect to staff requests, I'm going to ask that we keep in mind that we are in budget season. So data requests and extra informational types of requests are creating an exorbitant amount of time on staff as they're trying to go through budget. So I'm going to ask us to give them some grace and let's focus on the budget. I think we all realize how difficult this budget is relative to budgets in the past. Also, when we're making requests, let's always remember any of those data requests, the manager has to be looped in on those requests. He and I talk on a daily basis, and as he is trying to navigate and dole this information out, I've been pressing him to stay focused on the budget, and then I've gotten information back that are asking for a tremendous amount of data, which is all in bounds because we're trying to do our jobs. But if we have to prioritize, that budget has to take top priority, and that should take, staff should have full visibility to that first and foremost. So I'm going to ask us all to adjust to that. If there's something that you really need, please come to me and let's figure that out. And then, Mr. Manager, I'm going to ask that what you do is, again, prioritize the budget. The secondary requests that come out, they'll just have to be pushed out right now so that we can get through this budget. I know you guys are trying to hit a deadline. So with that being said, well, are there any questions, quick questions? Hearing none, I will turn it over at this time to our manager to get us kicked off.
Thank you, Mr. Chair. As you mentioned, I am really excited about today's agenda. You have 2 topics for discussion. Both topics are aligned to your health, equity, and wellness priority. The first item, access to care. This is an item that was rescheduled from our board budget retreat. You may recall, because of the inclement weather, we had to adjust our schedule, and this was the item that unfortunately we were not able to cover at the retreat. This item specifically was highlighted by Commissioner Griffin at your fall retreat as one of his areas of interest, which of course is shared by many of you. And as a result of that presentation back at the fall retreat, staff had put together a follow-up, which originally we were planning to present at the budget retreat in late January. Because of rescheduling with the inclement weather, here we are today. So Ben Chambers is going to tee up this presentation, and he'll be joined by some others that he'll introduce as well. So, Mr. Chair, please recognize Ben.
Ben, you are recognized.
Thank you. My name is Ben Chambers. I'm with the Public Health Department, and I'm here to coordinate an access to care presentation for you. Just like with the session at the budget retreat, we're going to start with a balanced scorecard update and element from Michael Griswold.
All right. Well, good afternoon, everybody. Thank you, Chair Jarrell, Vice Chair Altman, members of the board, and County Manager Bryant for the opportunity to be here. So today, as Ben mentioned, I'm here to provide an overview of county investments and walk you through the measures that we're tracking on the balanced scorecard as they relate to access to care. So before we get into the specific measures, I do want to ground us in the scale of the county's commitment to access to care. And so in FY26 alone, as you can see on this slide, we are investing nearly $268 million across various services that touch on access to care. Since 2018, that cumulative investment totals over $2 billion when you include ARPA funding. So that $268 million encompasses public health and medic services, Medicaid and SNAP eligibility, in-home aid and adult daycare, behavioral health and substance use services, Mecklenburg transportation services, and about $80 million in ARPA-funded projects. So these are the service areas through which the county most directly touches residents' ability to access care, whether that's connecting someone to a primary care provider, helping them maintain eligibility for Medicaid, getting them to an appointment through transportation services, or providing behavioral health support. Now, my colleagues in public health will follow me and speak in much greater detail about many of these service areas and the work behind these investments. So what I want to do now is just briefly ground us in where this topic sits on the balanced scorecard framework, and then we'll walk you through the specific measures that we're tracking to assess whether our investments are producing results. So as I did at the board retreat, I would like to call your attention to the objective 1.1 under our healthy and thriving community focus area, which is to improve access to county health and human services. So this slide shows the measures that we're tracking under that objective 1.1, which again is to improve access to county health and human services. So I want to walk through each one of these briefly so that we have a shared understanding of what we're measuring and why. So starting with our internal SMART goals, these are measures that, generally speaking, the county has more direct control over through the services that we deliver. So first, we track the percentage of families that receive a child trauma intervention through the Child Development and Community Policing Program. Our target for this measure is 94%, and most recently, we came in at 97%. This program connects children who have experienced trauma with intervention services, and the measure tells us whether we're consistently reaching families that are referred to us. So achieving 97% means that when a child is identified, we are following through. Next, we track the percentage of children served by Mecklenburg County Public Health who are up to date with recommended vaccinations by 24 months of age. Again, our target is 75%, and we met that target in FY25. Immunization by age 2 is one of the most foundational public health measures that there is, and it protects children during their most vulnerable period and has long-term implications for school readiness and community health. Meeting this target tells us that our public health infrastructure is doing its job on the prevention side with respect to this measure. We also track the percentage of residents living with HIV who have achieved viral load suppression, meaning that treatment is working and that they're staying connected to care. Our target is 80% here, and we exceeded it at 88% most recently. This is a clinical outcome measure, meaning that it doesn't just tell us whether people accessed a service. It tells us whether the care that they received is producing the health result that we're after. So exceeding this target at 88% signals that our public health system, again, is not just getting residents in the door, but retaining them in effective treatment. Finally, in our internal measures that we track the average wait time at the county's community resource centers with a target of 30 minutes or less. So our actual average here is 11 minutes, which would put us in the green range. And this is a direct measure of functional access, meaning that when residents come to us for help, are we making them wait? And an 11-minute average tells us that our service points are operating efficiently and that we are not creating unnecessary barriers for residents who have already taken the step of showing up. Additionally, we do track this measure at both community resource centers, and both exceeded this target this year, with Valerie C. Woodard Center at 15 minutes and the Ella B. Scarborough Center at just under 7. So now the two measures at the bottom of this slide are a little bit different in nature. So these, as I mentioned at the board retreat, are community level indicators, meaning that they reflect broader conditions in Mecklenburg County that the county influences but may not fully control. So first, we track the percentage of adults without a primary care provider. This measure tells us what share of adults in Mecklenburg County don't have a regular doctor or provider that they can turn to. This is, again, a measure of functional access. So whether residents can actually connect to a provider and receive ongoing care. That matters because residents with a primary care provider are far more likely to get preventive screenings, manage chronic conditions like diabetes or hypertension, and stay out of the emergency department for things that could have been addressed earlier. Now, I do want to be clear that the county doesn't provide primary care at scale, but we do invest in partnerships that expand access for uninsured residents. So this indicator helps us to understand whether the functional access landscape in the community is moving in the right direction. Again, our target is 16%, and the most recent result is 12%, though, as it's noted on the slide here, I do just want to make note that the survey question was modified in 2024, so we should just take some caution when comparing 2024 to prior years. Next, we track the percentage of adults unable to see a doctor due to cost. This measure captures residents who needed medical care but didn't seek it because they couldn't afford it. This is a measure of financial access, whether cost is standing between a resident and the care that they need. So the people showing up in this number are often disproportionately uninsured, underinsured, or on fixed incomes. And when they delay care, the consequences of that delay can compound, right? So chronic conditions can get worse, preventable hospitalizations can increase, and workforce participation downstream can drop. So for us, this is a signal of whether our investments in primary care partnerships and community-based health services are reducing the financial barriers that residents face when they need care. As you can see here, again, the target is 14%, and the most recent result is just over 13%, which indicates that we are moving in the right direction. Now, finally, we also recognize that geographic access, so whether services are physically located where residents can reach them, is equally important, and we are actively exploring ways to measure that dimension so that we can bring the board and county leadership a more complete picture of the access landscape in Mecklenburg County. So with that said, I'm going to turn the floor over to my colleague, Ben Chambers, who will continue the discussion on access to care. Thank you for your time.
Thank you, Michael. Thank you very much. I'm going to provide some additional context on the measures Michael referred to at the end of his list on community-level data and goals. Before I do that, I do just want to sort of touch base again on what primary care is. Michael described it very well. It's your usual source of care. It's the place you get a lot of those preventive services that can be so valuable. I also want to ground us in the vocabulary of different kinds of access we look at when we think of access to care. Michael mentioned financial access, there's geographic access, there's also functional access or utilization. And it really is drilling down on that utilization piece that we're going to talk about over the next few slides. So this measure comes from the annual community health survey that the Public Health Department fields, and it shows the percent of adults without a primary care provider. Michael already shared with you the 2024 result. This shows the 2021 to 23 result, so you can get a sense of the trend. Right now, that result is stable, or that trend is stable, and we'd like for the results to get as low as we can, so we do have some work here. Lower is better, though, for this measure. We have two additional measures related to access from the same survey. The first on the left in red shows the trend of the percent of adults in Mecklenburg County avoiding medical care due to cost. Here you see a small increase from 2021 to 2023. And then we do have that 2024 data point that's in the same neighborhood. The reason that's separated in the chart is, as Michael mentioned, there were some changes in the survey wording, so we want to be careful about a straight year-on-year comparison. In the chart on the right, you see a similar measure, the percent of adults avoiding needed dental care because of cost. With this measure, you see a little bit more of a straight increase, a leveling up. And again, that's the opposite of the direction that we want to see this measure move. And then we have the 2024 result there as well in the same neighborhood at 20%. In addition to our community health survey, there's another data source that helps us understand functional access or utilization, and that's NC Medicaid. NC Medicaid shared a data set with us in 2025 that shows the percent of adults with Medicaid in Mecklenburg County who have a primary care visit in the previous 12 months. This measure shows those who do not have a primary care visit in the previous 12 months. Again, we want that measure to be as low as possible. And what you see here, again, is sort of a picture of stability. The time period that they gave us the data for is from January 2024 through June 2024. We've asked multiple times to see if we can continue getting this data into the future, but that's what it shows us at the moment. Now, it's one thing to see data and numbers on a slide, and it's another thing to hear from the people who are trying to do the work every day in the clinics to bring access to care to residents who need it most. So at this point, I want to invite our two discussion panelists to join me here at the table as I briefly introduce them. Dr. Ray Feaster is an internal medicine provider at Novant Health Primary Care Clinic. And Don Holloman is the CEO of Cabarrus Rowan Community Health Centers, which operates Sugar Creek Health Center here in Mecklenburg County. So I hope everyone will help me welcome them. Thank you all for being here. So we have just a couple of prepared discussions to get their perspectives out on the table. The board will have additional time to ask questions at the end of the presentation. So first of all, thanks again for both of you being here, and thanks for all of the work you're doing day in and day out to bring access to the community. I want to start out with a question. What are your biggest concerns with access to care in Mecklenburg County right now? And either one of you can start. Please do speak into the microphone just so everyone is able to hear you well.
Well, I don't mind getting this started. I think about this a lot. One of the biggest barriers, I think, of course, is time with our working citizens who have to hold down jobs, and also our single parents making the appointments, getting to the appointments, and scheduling the time off, and having jobs that allow them to take the time off. I see that a lot in my clinic. Another barrier is trust. Obviously, there's some challenges with healthcare historically in certain marginalized communities. So even where access may be available, getting patients to trust the system to go in and get the necessary care that they need. Transportation is a huge one. When you have to hop off one bus to get on another and be at the appointment on time, and you can't be late, or the weather's bad, different barriers to transportation can be a huge impact to access to care. And the ability to pay, which I think is probably one of the biggest ones, and you've talked about that a lot. So those are some of my top concerns that I see in Mecklenburg County that we need to address, and Novant's making sure we address all of those.
Done.
Well, first and foremost, thank you for inviting me for this conversation. It's such a critical conversation that we need to have. Access to care is a right for all individuals with whatever community that you reside in. I definitely will piggyback on Dr. Feaster, if I'm saying your name right. I apologize. But access to care from our standpoint as a community health center is about touch points. It's about ability to be able to have accessible touch points regardless of an individual's ability to pay. One of the things that we have in this region is we don't have enough touch points that offer comprehensive health services. When I say comprehensive, I'm talking about medical, dental, and behavioral health services. A number of times we have our residents come into our touch points and we have to refer them out. And you know what happens when you refer somebody out? There's a strong possibility that they are not going to be able to follow through with that direction of care. But at a community health center site, we are comprehensive. We have the ability to deliver medical, dental, behavioral health, and a lot of other subset services that allows the patient to have a higher probability of completing the treatment plan. But some of the concerns that I have is touch points. And it's also, our patients are utilizing the ER like it's the primary care. And we have to do a better job in educating our residents of where these touch points are. One, they're afraid of, is it going to cost too much? Is it the lights? Is it food? Or do I get this tooth pulled? If they know where safety net providers are that are going to see them regardless of ability to pay, then they're going to come out and access those services. One of the things that my board chair, Robert Freeman, does a great job is illustrating one of the concerns. If an individual is not well, that means he's not going to work. That's right. That means he's not generating revenue for his family. That means he's not generating revenue for the economy. He's not going to lunch. He's not getting that gas pumped. He's not stopping at Family Dollar to pick up the school project. He's staying at home. Insert a community health center to that formula. That means that individual is able to go to work, able to provide for his family, able to stimulate the economy, and able to pick up his child's homework project on the way home. That is the impact of a safety net provider in the communities that we serve. So I would say increasing our access points must be a critical focus of what we do. Eliminating the need of the ER and educating our patients about the safety net services throughout the community should be discussion points that we should continue to have.
Thank you very much. I particularly want to lift up what Dr. Feaster said when she named those barriers to access: cost, time, trust, transportation. I heard her say that about a year ago at an HHS committee meeting, and that just holds so much in so few words. I found value in it. What efforts or partnerships currently underway are you most optimistic about?
So he did a great job of talking about the touch points. So one of the things I'm really excited about is our strategic partnerships with organizations like Compare Foods and Project 658, as well as the Latin American Coalition, who have allowed our mobile units to go into their spaces to deliver care in a new and innovative way, places where patients in the community feel safe and protected, where they may not always want to come into the clinics. So that partnership with our community organizations has been really something that we want to expand on. Other strategic partnerships in the community are with Parks and Recs, our libraries, and CMS schools. In fact, in January, we were able to host our second Health Fest, where we were able to partner with LabCorp and other organizations, Radio One, to provide free laboratory screenings for chronic diseases, as well as address some of the diabetic patients who were overdue for screenings. It was for free at Eastway Rec Center. We had a tremendous turnout and were able to provide service to over 100 patients. So we want to continue to expand on that. And that was all of, we were able to do that through that partnership with Parks and Rec.
I would say one of the first things that I'm optimistic about is everybody in this room. I mean, you're having the conversation. I've been doing this 25 years in 4 different states, and the hardest part is getting all the people in the room to start having the conversation about the same topic. Another thing that I'm very optimistic about is a partnership that we have with the health department. The health department has done a tremendous job in ensuring the safety net infrastructure, providing additional resources, and then the county has done an excellent job in being that support system to navigate us to additional resources within the community. We utilize our mobile services. We utilize additional partnerships. We have a strong partnership with the Salvation Army and Shelter Health Services. We work with the Charlotte Rescue Mission. We work with the Relative. We take our mobile unit directly to those individuals. And I'm proud to say over the last year have over 2,000 visits just from our mobile unit in between Mecklenburg, Cabarrus, and Rowan counties. So being able to utilize the mobile services to be able to expand the partnerships within the county allows us to be able to bring the services to the resident, which means that they are going to be more likely going to be able to follow through on the delivery of care.
Thank you. We know right now that this work sits in the midst of policy change, pointing in multiple different directions. We've got Medicaid expansion from the state, which is still unfolding and working its way through the system and is pushing more people into care or opening up opportunities for more people to step into care. We've also got more recent federal legislation that has introduced some policy changes that might limit access to care. So I'm curious next how your organizations are preparing for some of those state and federal policy changes over the next few years to take advantage of what we can, but also to sort of get ready for some of those impacts that might be coming our way.
I figured that. You know, every day something changes, and let's just be as transparent as possible from a state or federal level. We have done an excellent job in ensuring that we have Medicaid expansion. I don't think you understand the Herculean effort what that is. 600,000 individuals went from not having insurance to having some form of insurance. But we know that there are changes. We know that there are workforce restrictions coming down. We understand that there are proposed reimbursement structures that may be changing. What we have to do as a community health center, as a safety net provider, is leverage our partnerships with the county, state, and other federal officials to ensure that we're able to build sustainable models. That's what we've done. We've built a sustainable model in every community that we serve. But we also have to find the workforce. We have to be competitive. We have to invest. So one of the things that we have done at the Sugar Creek Health Center is we've leveraged our partnerships with the county and the state and the federal government to be able to navigate the changing environment of Medicaid on the state level and on the federal level. We understand that there's going to be workforce restrictions, that when a person used to be able to get recertified annually every 12 months, now it's going to change to 6 months. Well, what we've done is we've hired financial counselors to be able to be at the front desk and navigate those individuals through what their current eligibility status is and help them navigate those waters to additional resources. But when they walk through our doors, they're still going to receive services regardless of their ability to pay.
So I like that. So along the line of financial counselors, we also have been deploying our community health workers, anticipating how to help patients stay on Medicaid and learning what they need to do. That might look like connecting them to jobs to meet the requirement, connecting them to volunteer activities and opportunities, or educational opportunities to make sure they stay qualified to stay on Medicaid. Also understanding that application process. Our community health workers have been paramount in that. There are huge barriers to knowing what the qualifications are and how to navigate that. So as much as possible, deploying them to make sure patients understand the process and walking them through the actual applications to be able to get the necessary services. And he talked a lot about touch points, which I think is a critical point regarding access. How do we get patients out of the ER to alternative sites of care? And so we have been proactively adapting policies that allow us to expand our ambulatory care services, do more with our mobile units, as well as other alternative sites where patients can seek care outside the hospital in a more affordable and safe way, and also in a way that's convenient to patients, so it works on their schedule as well.
And my final question, you both talked about the importance of partnerships, and that's something the county embraces with you. Are there any other innovative approaches that you've seen or that you're exploring to improve access to care locally? You know, what might be worth expanding or starting out?
I think we see a lot of things on the front line. And I'll be completely honest. I know I told Commissioner Dunlap this a couple years ago. We completely underestimated the need for oral health in this county. When we stood up our Sugar Creek Health Center, we only did it with a mobile unit and 2 dental chairs because we were focused on the integrated approach, which was behavioral health, substance abuse, medical, and dental. Now we're underway with expanding our dental practice because our dental facilities are running, they are 2 months out. And we still take walk-ins. So it was underestimating that, but being able to pivot. Being able to pivot to increase access to care, and that's what we're doing, increasing the access through mobile, increasing the access through creating more dental chairs, increasing the access through hiring other individuals, and then partnering with agencies. Being able to bring the service to the person via the agency has allowed us to be able to expand access to care at a greater clip than it would have if we would just sit back and wait for people to come to us. So being able to bring those services to them, utilizing our outreach team, we have a wonderful outreach team that also communicates who we are and what we do. And our goal is if we get you in our network, we'll be able to provide the care to you. We have a care coordination department, we have patient navigators, we have financial counselors that'll work with you every step of the way to ensure that you have the full ecosystem of services at your fingertip right in your backyard.
Thank you both. Our panelists are going to stay at the front so they're available for any board questions as well. As we move towards the time reserved for board discussion, I do just want to put a few data points in front of you about how the county invests in access to primary care. So through the partnerships that Don and Dr. Feaster spoke to, on the left-hand side, you see the dollar amounts that we invest in those partnerships with our safety net providers offering care, especially to folks who are uninsured. In the center table, you see the number of people who are served across all of those partnerships. The really exciting thing here is we see an uptick in investment, and then we see an uptick in the number of people served. So we're encouraged to see that relationship, that more investment really seems to be doing the work. And then on the right-hand side, we have a couple of outcome measures because we know that it's not only about getting people into the clinic, but it's about the quality of care provided once they get there. So we have 2 outcome measures, one focused on the percent of patients with diabetes who have their A1C in control, and the percent of patients with high blood pressure who have their blood pressure in the appropriate range. You see smaller changes with these outcome measure results, which is sort of typical for those results, and there's more context around that we can share depending on what the board wants to get into as part of your discussion. Within your discussion, just like at the board retreat, we have a couple of questions to offer for your consideration to the extent you find them useful, and to help guide us in terms of how we make sure we're aligned with the vision. First, what role or roles do you want to see the county play in creating greater financial, geographic, and functional access to care for residents? And 2, what does moving in the right direction look like with respect to access to care overall or any of those buckets? I've given you a few examples of roles that we already play, just to prime the pump. And with that, Chair Jarrell, we're ready to turn it back over to you to manage discussion with the board.
All right. Thank you so much, panelists. Thank you for being here. Colleagues, I would just remind us, I know that everyone is passionate about this. I know we're going to have a lot of feedback for the panelists or even questions. What I'm going to ask, though, within our time, if we can really focus on the board consideration for staff, what they're asking for us to do. what they're asking us to answer, in addition to any comments or questions we have for our panelists. But we really want to make sure that they understand the direction and takeaway. So what we'll do is, for this discussion, we're going to start to my left and work our way to the right. Next discussion, we'll go the opposite way. So with that being said, normal time, Madam Clerk. We'll start with Commissioner Leek and go from left to right.
Let me first say thank you for being with us today. We certainly need this information. And as I think about my district, which is District 2, the first question I had, what districts are represented in the process of service? You talk about where you're located and how much it costs. My concern is mobility and information in the public to the community, where the resources are and how available they are. What will it cost the county to help? When I look at the numbers, starting out with 15,000, that's few people in this community being serviced. So help me understand, how do we increase this process, and especially for senior citizens?
So thank you for asking that question.
Just a little bit louder for me.
Oh, sorry. Thank you for answering that, asking that question. We've seen a lot of success with the mobile units where, to your point, we bring healthcare into those communities where access may be limited. So a little bit different approach, but even models where we have primary care providers on those mobile units who are able to manage simple problems, do examinations, but bringing the mobile units into the communities to provide mobile access to care. Also expanding on our telehealth services, which gives us reach to all of Mecklenburg County. So with our virtual visits and our video visits, and I know that sometimes the technology piece can be a barrier to some of our senior citizens, but we have folks who can help with that. And in fact, we have models where we are looking to set up actual video visit devices in certain apartment complexes. We've been partnering with some of the developers where we can walk patients through how to do a video visit on site to get their needs met.
And I want you to tell me, include male versus female. How do we get to the males to make sure that they're getting the services needed, getting the information, and especially our seniors?
Good question. Males.
Say that again.
I said, great question. Males can often be a little bit more challenging due to trust. What I see in my clinic is that most of the males who come to the clinic are usually prompted by loved ones. So I think strategically partnering with faith-based organizations so that they can give that communication to their congregants. I recently was on a panel at one of our local churches uptown on Trade Street, and we talked about that very thing. How do we leverage our faith-based organizations to reach our male congregants to come in and get important prostate cancer screenings, colon cancer screenings, things that they are normally reluctant to do. So I think, honestly, Commissioner Links, it's going to take partnerships beyond just doctors. It's going to take us partnering with faith-based organizations, community organizations, wherever we need to do to gain that trust to get both males and females to access to care.
Main word is trust.
Absolutely.
Thank you, Mr. Chairman.
Panelists, when you hear the bell, it is for us. It is not for you all. So if you're in the middle of a thought, or you're answering a question, the bell is just a trigger to us, so we know to move to the next one. So
that means for us to stop. Okay. Thank you.
Thank you, Commissioner Griffin.
Thank you, Mr. Chairman. Trying to follow the balanced scorecard piece, although we're on this slide here, it's kind of difficult. Don't go back to it, but it's just difficult for me. And I'll continue to have conversation with the manager about trying to track down what we're trying to do there. But the question I have, several for the panelists, what would success look like to each of you in 5 years in Mecklenburg County as relates to the question of access to primary health care? Since the county doesn't provide primary care, then the question is, what role do we play? The other question would be, there are 55% of the folk who are on Medicaid for the first 6 months of 2024 did not see the doctor in 12-month period, if I slide number 10. So the question would be, in terms of functional access, do we have any ideas about, is it transportation? Is it some of these other things that the panelists spoke of. That would be interesting to hear. The other piece for me, since you only spent $3.5 million of county money towards supporting primary care access, are we looking for the county to be the primary funder of primary care, or are we looking for the county to be more of a convener or policy advocacy? Because we have Atrium Health, we have Novant Health, the federally qualified health centers. So how do we get them collectively focused on a population of folk who are missing the trust, missing the oral health? I mean, what role do we play other than we can't finance primary care? We just can't do that as a county. So what role? And for me, data is an important process. How can you provide more data for us so that we can be the policy advocate for Novant and Atrium and the other services that are out there? The other question, financial access, geographic access, and functional access. I took a picture, and it's on my phone. I travel around, and, you know, Novant, Atrium, you have these buses, and for the last several months, I followed a couple of buses, and they only have about 4 or 5 patients in a whole neighborhood. So Novant and Atrium is having medical providers in the neighborhood, but people are not coming to those buses for OBGYN or primary care. So for me as a policymaker, it's where do I get the biggest bang for the taxpayer's buck? Do I advocate for more participation in terms of utilization of the services that already exist? Or do we find more taxpayer money and create more primary care providers? You can take any of those or one of the above.
Okay, this is I'm fortunate enough that my grandmother grew up off of Jeopardy, so we're good. I think we're prepared for this 4-part question. We're going to focus on success, functional, funding, and data. I'll start with success. What does success look like? Success looks like increased touch points. We decrease patient wait times. And we increase comprehensive care, which is somebody that can get medical, dental, and behavioral health under one roof. We decrease the reliability upon the ER, so those individuals who have urgent matters can go directly to the front, and those individuals who don't have urgent matters can come to a primary care provider. Now, we talk about functionality. I know we've used the word mobile clinic multiple times, but I think you have to understand when you are able to bring the access to the person, it changes a lot of things. So if we're talking about our older population, our geriatric population, we have to be able to bring our mobile unit to assisting living facilities, to the nursing homes, to the recreational centers. We're partnering with the county to do these things, to be able to bring those services to that population, to hopefully put a dent in that. Now, we talk about a funding model. One of the best funding models is not to be dependent upon one funding source, okay? But we all have to have skin in the game. You know, the county has a responsibility to convey. That is correct, and they have done a phenomenal job. But you guys have also taken it a step further by being an investor, because you are investing in the lives of the residents within the community, and that means you have skin in the game, which allows us to be able to increase access to care. But the data is key. Data is everything. We utilize data to make all types of decisions, but the greatest thing that we did is we use the data to see where people are coming from so we can bring the actual service to them. We take the data and we target the high need areas and bring services to them, because what that does is it allows our current brick and mortar clinics to be able to see more patients who are coming in by us decreasing the wait, because we're bringing the services to a marginal community.
And I echo what he was saying, all of the things regarding what success looks like in terms of touch points. I would also add to that the timing. So you talked about the mobile units, and one of the things that we have to do to optimize that is to make sure we're in the right places at the right time. So in an ideal state, it would look like convenient care, where patients can go and to seek health care and get health care in a time that works for them. Current state, most health care, with the exception of emergency medicine, happens during banker's hours, and we've got to take advantage of after-hours care to allow those patients to come to care when it works for them. It may be after 5 p.m. So how can we innovate in ways to do that? And that includes our mobile units. If we have a mobile unit in a neighborhood at 10 a.m., a lot of folks are at work at that time.
That's right.
So looking at doing things differently to create that convenience factor for patients as well.
Thank you. Commissioner Powell.
Thank you. So I'm going to answer the questions, and I think what Dr. Is it Easter? Easter? Oh, thank you thank you both for your work, because it is so important. And my background is healthcare, and so some of the things you're talking about, I experienced in the past, but I even see it now, and especially as insurance becomes more unaffordable and everything's separate. You have to have insurance for your eyes, insurance for your teeth, insurance for your mental health, and you're like, what is happening? It used to be that if you had a problem, you had insurance, you were okay. And so healthcare is just really scary right now. Anyway, what I would like to see, and you talked to some of it, my background's healthcare. You couldn't say I don't want to work on Saturday. You have to take care of people every single day, 24/7. And so if you are trying to meet the needs of people who are desperate for healthcare, you have to be available non-banker hours, So I want to see that. How do we work together with partners to provide care at times when people need it? Because the emergency rooms are overflowing. You could put cots in there for all the people that are showing up in the ER. And so I love when Commissioner Griffin talks about the mobile units, because I remember when we opened some of them with Dr. Garman Brown and how excited we were about the potential and how do we meet the potential, because we can't meet it if we're not, like you said, optimizing it. How do we optimize it? So that's what I want. How do we offer hours that are reasonable for folks that need health care? How do we optimize the mobile units? How do we optimize partnerships, even beyond our health care systems? The Foundation for the Carolinas could be a great partner in helping solve this problem. And, there are all these businesses want tax incentives. They could be part of the solution as well. And also advertising, I've seen oral health, dentists volunteer to provide care. And every time that they volunteer to provide care in a mass setting, it's always kind of sold out before it starts, all the slots are taken. And so how do we do more of that more often on times where people can come? And you guys keep talking about where the needs are. The needs are everywhere. And so, you might be able to get extreme needs in the city of Charlotte, but I have to remind everyone that the towns have needs too. And so that's what I'd like to see. Thank you.
Commissioner Townsend Ingram.
Okay, I'm going to try to do this without editorializing, but both of you, thank you so much. Actually, it kind of puts our mind at ease when we see professionals like you with the data that you have. All of the things that you mentioned at the very beginning, Dr. Feaster, the time, the trust, transportation, ability to pay. I wanted to ask if childcare, have you seen that as a barrier? Because not being able, as a mom, not being able to get to a doctor, you're going to be concerned with your child if you don't have somebody to watch your child. So that's one question. Going through the three things that you have up there, services and partnerships, planning, data monitoring, and policy advocacy. For the first one, services and partnerships, how can the county, because the same questions that you have, I have of you for us, how can the county facilitate those partnerships, begin to facilitate those that are needed in places where people need? For instance, I live in District 2, as Commissioner Leek stated, so Five Points Co-op. Can we begin having or conversations about a relationship there so there can be some kind of medical care there? How about Three Sisters Market? Because if we begin having conversations about that, I think that it would actually spur the development of both of those facilities, and economic development would follow. Arthur touched on the scorecard, and I guess this is for our team. Transportation, we didn't mention anything about medic and the wait times, and I know we've got a study going there. But what my concern is with the data monitoring, because my background is synthesizing data and retrieving data, and it seems like every time we ask for data, it's the wrong time, or we can't get it because there's some kind of barrier, or we're not measuring it, or we didn't measure it before, or there's always some kind of barrier to getting data, whether it's HIPAA or something else. And if we're not measuring the right things, then we're not going in the right direction. We can't tell you what direction we need to go in. We're wasting time. We can't really see that. So with regard there, I have some concerns about how we collect data, because we can show data and make it look like what we want people to see, like we're doing well. But if we were doing so well, then we would have bigger improvements. So my question is, what do you see as better? For me, mental health care would get more, and we would have more preventative health care rather than, being reactive. There would be more preventative, especially for mental health care, because mental health care is frequently weaponized. It was weaponized against me. So I know that that is a huge issue. Have another question, but if you could just focus on those, and I'll jump away from policy and advocacy later.
So I'll tackle a couple of those things that you mentioned. You talked about, is childcare a barrier to the parents seeking care? It absolutely is. And currently in my clinic, we welcome children to come in. And so if you have to bring your kids, they got pulled out of school, feel free. Do not let that be a reason that you can't come see your primary care doc. We'll figure it out. They may be screaming and yelling while I'm looking in your ears and your eyes, but definitely if you have to bring your children to the clinic, unless they have a no child policy due to some outbreak, bring your children with you. We allow that all the time in my clinic. In terms of daycare, childcare, and the affordability piece, one of the things that I am seeing is those folks who make too much to qualify for assistance for childcare, but cannot pay the mortgage price that it costs to, and we've got to figure that out. That is a true barrier, and I currently do not have an answer. I think that's going to take a collective effort to figure out how we can make child care services more affordable so that people can go to work and also go take care of themselves and get the health care access they need. So that was a great call out. You also mentioned the West End Co-op, and would there be an opportunity to provide some primary care services there? One of the things I touched on earlier is looking at how we can expand our virtual services to specific locations. So I've had some great conversations with a local developer who actually does a lot of affordable housing in Charlotte. And he specifically asked me if once his projects come online, can Novant Health do some type of virtual visit or video visit for the actual residents that live in that building? And the answer is yes, there is a way to do that, and we're exploring that and looking at making that a reality. And that can also exist potentially in churches and other settings of care where there is trust and it works for people. So exploring on that opportunity to bring virtual care, and at the same time, not allowing virtual care to be the end all to be all, connecting those patients back to a primary care provider. Because in Novant Health, we continue to hire providers, honestly, on a monthly basis. New providers are being added, and they have capacity to see patients. And we take care of patients regardless of their funding source. So getting those patients to the clinics, that's one of the things that we have to partner with you all on doing. You also mentioned, there was one other thing that you mentioned about access, you were saying in your districts. So one of the things that we want you all to feel comfortable doing is if you see a healthcare gap or desert in your district, speak up. Let Novant and Atrium Health know. We think we're doing the right things and we're in the right places, but we're two of the people to talk to and say, hey, how can we strategically make sure that gap is filled? It may not look like opening up a brick and mortar, which is not always financially feasible, but it may be looking locally to see who's available to provide that care and how can we get the patients there. So I think we can do a better job of partnering with each other to meet those needs.
Thank you.
Commissioner Rodriguez-McDowell.
Thank you, Mr. Chairman. I was just trying to reconcile the, on slide 14, where it shows that our investment in primary care partnerships has been constant at $3.5 million, but it does show an improvement in FY25 of the number of uninsured residents served. And I was just wondering if there's a story there that you could tell so that we could understand how our dollars are impacting. That would be great to hear. I was wondering if our role, when looking at the questions, is part of our role to be like MEC Playbook, you know, where we're looking for the areas, like Ms. Feaster just said, you know, places where there might be deserts, where we need more access to free care. Like, is that our role or is that their role? Like, I'm unclear about that, you know, just, you know, who does that? Is that us or is that them? It's like their business model where they look, you know, where the deserts are. And also, one last thing. On the balanced scorecard where we see, I don't know if this is just one example of many, but like it shows that we're hitting all of our targets or meeting or exceeding our targets. And so my question was, then do we change the targets or do we go, okay, great, we're hitting our targets and let's look to other things? You know, I'm just curious about that. So that's pretty much where my mind was going.
All right. I might go to Michael first just to answer your last question while it's fresh in my mind.
Okay.
And we'll take care of the other two after that.
Okay.
Sure. Commissioner, I appreciate your...
While Michael is coming up to respond to your question, regarding the scorecard, I want to remind you the intent behind Michael providing you a briefing prior to each topic being discussed. He's sharing with you what we're currently tracking. And then what we're seeking from you, from the board's perspective, is this the set of metrics that you believe we should be tracking? Are there other areas that we should be considered as well? And then pending that conversation, we'll take a look at the targets, make sure they're ambitious as we've done in the past. So this, in addition to you asking questions, we also want to get some insight. As Commissioner Griffin said, he and I have had a lot of conversations about, from his perspective, what we should be tracking versus what we're currently tracking. So I want to make sure you don't lose sight of that as well, because when we finalize the initial draft and we bring it forward to you in the next month, I want to make sure that we consider all the feedback that we received from you, not just today, but also when we discuss the other board retreat topics as well.
So just to clarify, does that mean this is not comprehensive of everything
It's not what, no,
that we're tracking
no,
for that category?
This is just specific to this area, yes.
Yep. So just to answer your question, so we go back to go forward. So for each objective, we start with, you know, what are we trying to accomplish, right? So improve access to county health and human services. We would then go through and try to identify, you know, what are the, I guess, the needles that we'd like to move forward or that we'd like to improve on, and how would we know whether we are successful in those areas? And that's how we ended up with these measures, right? So trying to improve access to care, well, that means, you know, making sure that we vaccinate our kids, or they go through the CRC's wait time is less. So what I would say specific to your question is the scorecard is intended to be a scorecard, if you will, of all the things the county does and the results that we're trying to accomplish. What that means in practicality is that in some instances, we will achieve those, and therefore, we might shift into more of a maintenance mode in some areas. I think that is, for me, that's a positive, not a negative, because that helps you identify the areas within the scorecard, within the county that we need to focus on. So for me, a green doesn't necessarily mean we automatically need to change that target. Certainly, we can have those conversations, and if we realize that some of the targets are not as ambitious as we'd like to be, certainly there are opportunities for that. But in this instance, I would say that this, certainly, if the board would like us to measure something different, we're open to that. But as it stands right now, this would say that, for access-wise, perhaps we're in a good position, and there could be other, areas in the scorecard that might need more focus. But overall, I would say that just because we meet a target in one of these SMART goals does not necessarily in and of itself mean that we would change a target or that we would try to identify something else to measure. That could just be an indication that for that one instance, we are moving in the right direction, if that answers your question.
It does, but it brings up more questions, but my time is up, so I can't keep on asking.
Absolutely.
Thank you, Grizz. The Grizz.
I will jump back in to answer the question about the data point. The way I understood it was, why is there a lag essentially between when the investment goes up and when the number of people goes up? Is that?
No, it's not about the lag. It's about it looks like we're improving.
Yeah.
And I'm just saying, what's the story of what we're doing that's making that improvement?
Right. So really, it's all about increasing touch points, as Don mentioned. We've seen multiple of our partners open new clinic locations and touch points. The Sugar Creek Health Center is a fantastic example of that. But think of the ARPA dollars that also went to C.W. Williams, to Charlotte Community Health Clinic. They're opening new clinics. So as they open that space, they're able to start to fill it with patients, and that's what really ramps this up. We expect that to continue to improve in FY26.
All right, thank you.
Commissioner Meyer.
Thank you. First of all, to staff, I love this format. I think it's wonderful. I love the guiding questions, and I think it's just really helpful for us to stay on task. So thank you for that. And to answer the questions, pretty much what everybody's been saying. I think the way forward and the direction I want to move in is partnerships. And kind of like Commissioner Rodriguez-McDowell said, and we might have this, but a map of where we're lacking the clinics, because we're not the clinics, it's all our partners. And just to kind of say something kind of obvious, is Atrium and Novant, who they're sitting on the money. And, partnering with them and them investing in all of these clinics is extremely important for our community. Healthy communities, healthy for everybody. So, Charlotte Community Health Clinic and your clinics and Care Ring, et cetera, are the ones that are doing the work. And I think that's where the investments need to go. Comprehensive, I think, is extremely important, and I don't know if all of them are comprehensive, but I would like to see us go in that direction. I think that's incredibly important. So, and I know, of course, money's tight, and I want to say we need to increase it, but looks like we're doing well here. And I don't know if we can increase it, but I think we're moving in the right direction. So kudos to staff. Thank you.
Thank you. Commissioner Dunlap.
Thank you, Mr. Chairman. Like others, a couple of things you notice. First, on page 5, the concern there is that if we're already meeting the targets, then our proposed target is not high enough. I mean, because that says to me we don't have anything to work on. So we need to hone in on what the actual target ought to be so that we can see whether we're moving forward or not with that. In addition to that, I think Susan pointed it out, but I didn't get the answer that I was looking for. On page 14, when we see the increase FY24 to FY25, we see a 3,000 number increase in uninsured residents being served. But if you take that back to the dollar sign, then there's no additional money allocated for that. And I had the same question. So what's producing the increase in number of unserved residents being served if we're not adding any additional dollars. The other thing is, of course, our partners at Atrium and Novant recognize the fact that when we have increased health care, then we reduce the emergency room expense. So they ought to want to be greater partners so that we can reduce the cost to them. And then the last question I had is the question relative to reducing the cost. So one of the things that we do as a cost barrier is we have these fees that are assessed for certain things. And so the question becomes, how can we reduce fees that we charge to increase greater access to care by reducing cost?
So I can answer the question about the lag here. Others may weigh in on the fees after that. So basically the story is from FY22 to 24, you do see that investment go up. It took some time for that investment to build the buildings and clinics it was intended to build, and for those new locations to do the community engagement they needed to do to let people know, hey, we're here, we can offer you these services here. And we start to see that happen in FY25 in a big way. So that's why you see there's a sort of slight mismatch between the years where the funding increases and the years where the people served increased. And it's just about the process of opening new touch points to Don's.
So as it relates to that, then, again, I'm not sure where the goal ought to be because we're seeing the lag. If we increase by 3,000 people and just with the $3.5 million increase, how much more can we get out of that $3.5 million?
That's a good question. We do expect it to go higher this fiscal year. I don't have an exact projection for you, though. We just haven't done that math. I do know there was a question about the fees, and I want to make sure there's time to speak to those as well.
Thanks, Ben. What I would share with the full board regarding fees and partnerships, our staff, we are having internal conversations with the teams over at Atrium, Novant, and our community health centers as well. Those discussions first is to focus on educating ourselves. You know, what are we doing as separate organizations relative to access to care? And then once we educate each other, then we're exploring opportunities to enhance our existing collaboration and partnership as well, with the hope that although things are tight financially, we can leverage each other's services that also may have an impact on the fees as well. Those conversations are going really well. The partners have embraced it, and we're looking forward to what that will materialize. We're not there yet, but we're moving in that direction.
Commissioner Altman.
Thank you. So on the question of what is the set of metrics to track, looking at the objective 1.1 balanced scorecard slide, everything is important, but we do know that what we don't measure doesn't get as much focus. And so I would certainly continue to maintain the measuring of vaccinations for children up to 24 months of age and the suppression of HIV viral load. But I would want to see a new metric around access to telehealth through county assets. And I heard, I love the idea of supporting that work through churches. Also, I think we talked at our retreat about making this potentially accessible through county parks, county rec centers. There's a lot of good primary care that can be achieved remotely. And I know that that's been happening through Roof Above at the Clanton on the Rise. And it seems like it's occurring in a lot of our CMS schools. And so it seems like we've got a lot of good precedent for doing some great work. And so I want to see us, I would recommend a SMART goal around targeting telehealth, which will give access, not the best or the perfect access, but better than no access, with an equity lens to close gaps. So thank you, Mr. Chair.
Thank you, and thank you, colleagues. Also want to say to our panelists, Thank you for being here. Ben, you did a great job moderating. A couple of just thoughts that I have around this issue. First off, I would say I'm really concerned about an idea around setting goals where we really have there are variables that are out of our control. And that's just not relative to this, but just generally speaking, I'm really always concerned about that. And I say that to say this, Mr. Manager, one of the goals that I would like to see us consider would be an idea around a direct-to-consumer model, meaning I would like us to identify census tracts, our most vulnerable census tracts, where these underinsured and uninsured folks are.
Right.
I would like us, when we talk partnerships, I would like there to be partnerships with grassroots organizations that are deployed into the community, because what we can control is who gets the information, who understands that there are FQHCs out there, or health clinics, and what is delivered, who physically can go door to door in a neighborhood and deploy that information so that we can track, Mr. Manager, and say, okay, we know that this was delivered to 101 Main Street. We know we had either a delivery or even a physical touch with someone where we provided education, because I think that's something that's within our control. Once we understand the numbers that we hit, so we understand, we start at the macro level. We understand the targets in our most vulnerable census tracts. It's 100,000. We deploy our partners to allow us to know how many touches we have. They canvass those areas. They set follow-ups for us and our partners. Our partner organizations can then track those individuals. So when we see numbers rising, we can have a better perspective on what we're attributing that to. Is the numbers rising just based off of 157 people a day moving here? Or is it based off real education or access? I think sometimes we're relying on our faith community partners have been awesome. All of our partners have been great, but we continue to do this and rely on all of these partners in isolation, and we continue to have very limited results. And we're not scaling. We're not scaling our results, right? So we've got to move to a space to scale, but we have to have a better perspective around that macro level, in my opinion. And I think we can deploy some of these grassroots organizations that would be able to go and deliver that information. That's number one. Number two, it doesn't appear to me that the system is overburdened, right? So would that be accurate, Mr. Holloman and Dr. Feaster? It doesn't. It's overburdened in the sense that people are using emergency room for primary care practice, but not necessarily overburdened with access, other touch points out there. Is that fair to say? That's fair to say. Okay. So with that being said, that's where, Mr. Manager, I would like to see some other level of ways to educate and inform, and beyond us doing the billboards uptown or bus, whatever we do there, which is effective. I'm asking, in addition to maybe considering some sort of identification in the areas that I stated previously. And so with that being said, I want to say thank you all so much. I agree with Commissioner Meyer. I love the format and the setting. It's great. And I would encourage colleagues, if you have additional feedback, to please get with the manager and shoot a note for him and staff. So thank you.
Thank you very much for the time.
Thank you.
All right, Mr. Chair, the next item on your agenda, as I stated earlier, is also tied to your health equity and wellness budget priority. This is in response to a request by the board to receive an update from Alliance Health. With us today, we have Robert Robinson, CEO of Alliance Health, along with some of his team members who he'll introduce. So at this time, I'm going to ask that you recognize Mr. Robinson.
Rob, welcome. Thank you. Great to see you both.
Hi, good afternoon, Mr. Chair, Commissioners, Mr. Manager. It's a pleasure to be here today. It's been a while since we've been here, and a lot's changed. So we're here to give an update on service availability for the citizens of Mecklenburg County with mental health, substance use, intellectual and developmental disabilities, or a traumatic brain injury with Medicaid, or who are uninsured. We serve people who are uninsured with state and county dollars. So we took over the responsibility of managing care here in Mecklenburg in 2021. When we began in this community, there were clear goals for us to improve and expand care. And we've made a tremendous amount of progress in that area, which we're going to talk about today. Before I do that, I do want to first say thank you to the commissioners and to the county manager's office for your partnership. We are grateful for your trust in us to manage your dollars, to work with us to improve, expand care in the community, and you're going to hear about all those efforts today. But before I turn it over to Sean, Sean's going to be your keynote speaker to talk about the service expansion. I did want to talk a little bit about Alliance Health. I know there's been questions because of the complexity of the mental health system. In Mecklenburg County, you have 9 health plans in this community who are responsible for managing some level of behavioral health, addiction services, and intellectual and developmental disabilities. We are one piece of that. We are responsible for managing care for people with severe mental health, severe addiction issues, just about everybody with an intellectual and developmental disability, and those with a traumatic brain injury who have Medicaid or who are uninsured. So our primary responsibility is to those citizens of Mecklenburg County with the most complex, the most severe, and the greatest needs. And that's the work that we signed up for. That's the work that we want to do. It's very difficult work, and we can't do it without partners like yourself. So again, we're a Taylor plan, and Commissioner Griffin reminded me that he remembers years ago there was a community mental health center here in Mecklenburg County who actually delivered care for people with Medicaid and state dollars. And that goes back to, like, I think 1960, where there was a community mental health model where if you needed services, you just went to the community mental health center. Back in 2002, the federal government said you cannot receive Medicaid dollars, use those dollars to provide care, and manage yourself, right? There's a conflict of interest. So with that, the federal government told North Carolina, you either deliver the care or you manage the care. So we transitioned from community mental health centers to what's called as a local management entity, or LME. You probably heard that terminology. And under that model, we were responsible for managing care for people who are uninsured. We receive state and county dollars. So fast forward a decade, the state had a tremendous overspend in behavioral health services. They said for Medicaid, so they asked us to not only manage state and county dollars, but to also manage the Medicaid dollars on the behavioral health side as well. So that change occurred in 2012, and we became LME MCOs. MCO, of course, stands for Managed Care Organizations. So that was back in 2012. Fast forward again another 10 years, 12 years. We then transitioned to what we are now, which is a Taylor plan. We are under the old LME MCO model, we were responsible for anybody with a mental health system or a mental health issue or a substance use disorder. Under the Taylor plan, the mild to moderate, the people that just need basic or are not receiving mental health service, transition to what's called the standard plan. They're responsible for about 85% of the Medicaid. Those with the greatest needs that I talk about transition to a Taylor plan. But the other change is we're also responsible for the physical health as well as the pharmacy benefit for those with the greatest needs. That's what we've been advocating for years. So I don't know if that cleared up any of the confusion. I know it is complex, but I'll be happy to answer any questions about the system. So right now, there are 4 Taylor plans, right? If I go back to community mental health centers, there was 1 in every county. There was about 100 in the state of North Carolina. Through the years, through those transitions that I talked to, we're down to 4 Taylor plans. Alliance is the one we serve the Triangle area as well as Charlotte. We are the only Taylor plan that serves the urban setting. That's our kind of our niche or our bread and butter. We have a couple of populations that we're responsible for. Those are the Taylor plan. Again, severe mental health, severe substance use, intellectual and developmental disabilities, and traumatic brain injuries. Whole person care for that population. We also serve those Medicaid Direct. Try to make this as concise as possible. Under the Medicaid Direct, we manage the behavioral health and IDD services. The rest of the population, the physical health and pharmacy is managed by the state. The population under Medicaid Direct are populations that are not, the state is excluded from full managed care. It's like Cap A, Cap C, Cap DA are a couple of examples of people that are served under Medicaid Direct. And then last, of course, is the non-Medicaid population. These are folks who are uninsured, underinsured. We receive state dollars and county dollars to manage that population. And as I think I've talked about a couple of times, it is woefully different, the amount of funding we get to serve the uninsured, underinsured versus what you get as a Medicaid. Medicaid expansion was a game changer for us. We enrolled many, many more folks who got basic services under using our state and county dollars to having the access to a full array of benefits under the Medicaid. Staffing, we're a staff of about 1,400. We do have an office here in Mecklenburg. There's well over 100 staff that are located here in Mecklenburg. Most of those are staff that are engaged either with the member directly or with our providers. Their job, while we have an office here, most of their job is working with members at locations that's convenient for them. And I always want to emphasize this last, we are not a service provider. We are a managed care organization. We contract with providers, 5,000 across the state, to deliver the care that is needed, no matter where the residents live from the 7 counties. So that's an overview. Again, after Sean's presentation, I'll be happy to answer any additional questions.
Thank you, Rob, and thank you for the opportunity to be here this afternoon. Really appreciate the conversation and want to echo our population, as Rob said, is challenging, and these are groups that need partnerships. There's not a system in this community that our members typically do not touch. From social services, juvenile justice system, adult justice system, schools, public health, you name it, our populations are involved. And the other thing, just to echo from the last presentation, one of the things we're really striving for is, one, we have to build a network that's accessible to our members. And you're going to hear a lot today about numbers served and access. We didn't go into a lot of detail about what are the kind of outcomes of these services. With behavioral health and with this population, really it all starts with engagement. Without access, you really don't have anything. And the idea, too, of these integrated settings and integrated systems, in our individuals, think about, if you can kind of put yourself in their shoes, your worst day, multiple stressors, multiple things to take care of in a day, very little supports, the car's not working, friends are out, none of the things you need to help manage, and yet you have to figure out how to get to multiple appointments, because one of the things that we still know that the population we manage still die an average of 25 years earlier than non-mentally ill peers, and from preventable causes. And a lot of that is because of access issues into getting the care. So we really believe it's important not just to have behavioral health care, but get as many care needs met in one setting, and really want to spend some more time building that out. We have some creative partnerships here in Mecklenburg, and that's going to be a lot of our future direction. But we were asked to provide an overview of our network. So you can see here we have, this we just provided for today, more about our behavioral health network. We have about 257 different entities that employ close to 3,500 clinicians. You know, that number can be a little bit misleading. Some of those clinicians may see one of our patients, some may see hundreds, some of them are employed in big systems, but we do have some clinical capacity. We have 12 entities who just specialize in serving individuals with substance use disorders, but some of our providers also who do mental health services treat both conditions. And then a big thing you hear a lot about in the state these days is treatment for children with autism spectrum disorders or autism. A lot of providers in that space. When you have an urban area, it's very attractive. One, there's a big population of need. It's also easier to deliver these services. The reason we're highlighting this is while the number of entities are growing, there is some concern within the state and actually nationwide that maybe there's becoming too much access and people are starting to provide services to meet maybe financial needs and not necessarily what's always in the best interest of youth. And we've seen tremendous, tremendous growth in that network and the spend there. And the reason I highlight this particularly, one of the things about an LME MCO that's a little different, we're kind of part of the public system. If we save money by efficient care, we invest it back in the community, and we're going to share some of what we've invested back to. If spending becomes out of control in an area, it really lessens our ability to make some of those financial investments. Anyway, another interesting component of the Tailored Plan is something called care management, tailored care management. That, again, our population is difficult to serve, likely you're going to need help navigating a very complex system. Typically, if you're in our system, you have pharmacy needs, behavioral health needs, various physical health needs, potentially occupational speech, home health, you name it. We need people to deliver that kind of on-the-ground care management to help coordinate services. We're very fortunate that the model in the state allows both the health plan and provider entities that were certified to provide this care management. You have 37 of those entities in this community that serves 17,000 of your members. What we're also very proud of is when we got to the community, there was some concern that the previous managed care entity maybe wasn't as inclusive and didn't do enough to bring along historically underutilized or minority-owned providers. And we really thought that was a problem. We focused a lot on that. We're proud to say of the 37 entities providing care management community, 15 meet that definition. And Alliance, in partnership with the state, funded the development of a network that helps support all those providers. So someone who could come in, provide technology, compliance, training, all the things that help make these providers successful. So it's allowing these smaller, mission-driven organizations that maybe don't have huge back office support to deliver community interventions in communities where the staff are from, and we think that's a big difference for us. All right, so just a little bit about Alliance. We are allowed to maintain a closed network for certain behavioral health services. Certain things the state requires us to have open, outpatient services, psychiatric services. The child service called ABA is an open network service, and there's everything in physical health is open, and certain things are closed. In the past, I think this has been misunderstood. A closed network doesn't mean no provider can get in. It just means that the health plan can make some decisions about the providers we choose to accept. For instance, we every year do a look at our needs and gaps, and we determine are there things missing. So instead of just having a bunch of providers join our network for things we maybe don't necessarily need, we can go out, hand select, and at times help fund organizations to come into our network. There's a very expensive team-based service that is intended to serve people with serious mental illness. It's called a Serve Community Treatment Team. It can cost up to $250,000 to start one of those programs. Many of our small behavioral health providers don't have that kind of capital just to outlay and wait for a year or two to make their money back. But we knew in Mecklenburg we didn't have enough of this service, so Alliance funded 3 providers to add this, and that led to increased access for that service for people with serious mental illness. All right. The other question was about what is the local capacity. So in Charlotte, and again, as Rob said, we don't provide these services directly, we contract. There are 163 adult psychiatric inpatient beds. Now, remember this, while that may I don't know if that number sounds big or small, but it's to serve Alliance members, but it's also to serve all the people with the commercial Medicaid plans, people with Medicare, anyone sitting in this room who might need it on their commercial insurance. So, the problem is when we look at access, we're a piece of it, but these services tend to, like hospitals, they serve everyone in the community. And this is one of those areas it's very limiting for a health plan to just go and build a hospital system. This is where communities in the state have to come together. There are 37 child psychiatric beds. You have one of the still few child crisis, facility-based crisis service facilities in the region. It's kind of like an inpatient setting for children. It's a little less intensive. The need of the kids is a little less severe. You have 148 residential substance abuse beds that do things from treatment to detoxification. A gap in the system, and it's a statewide gap. In the actual county themselves, there's no adolescent substance use treatment beds, and that's an area for further exploration. In the community, there's 42 residential psychiatric treatment beds. This is an intensive residential service for youth. Typically, there are locked facilities with 24/7 awake supervision. You've probably heard a lot about that in the past couple of years as the children in the DSS crisis became worse. Kids with more severe needs needed to be placed, and you can see there's just not a lot of these beds. And then there's 159 group home beds. We are fortunate, and Mecklenburg is fortunate, that just across the border in Rock Hill, there's one of the biggest psychiatric residential facilities in the region with New Hope, and they've been a reasonable partner of ours in taking youth with complex needs. So one of the things we wanted to highlight is we talked about before that if we have savings, some efficiencies, and certainly during the COVID time when there were less people seeking care and we were getting still our kind of standard capitation payment, the money we get from the state to manage care, we're able to take some of those dollars and reinvest. And often these things are done in partnership. So some of these services are online. And we've been investing for the last couple of years, and some of them are coming online. Like a big thing, there was not an adult facility-based crisis for adults in this community. So if an adult was experiencing a crisis, the only location for them to go would be to an ED and then to an inpatient hospital. And they might not need that level of care. In partnership with the county, due to their generous contribution, the state, and Alliance, there's a facility being built that should be opening later in the fall. We have a expanded child crisis facility, although it's not in this area, it is available to children from Mecklenburg. The other thing we partnered, again, a combination of county, a private foundation, and Alliance. It was the opening of the Steve Smith Center, which is a 24/7 behavioral health urgent care. It works typically like a physical health urgent care, that people can come in to get treatment needs, whether they've ever been in treatment before. Maybe they've been in treatment, but they've had gaps in care. They can't get in to see their psychiatrist or their doctor, and they need medication. These urgent cares can bridge. They can also be a diversion point from the emergency department. More individuals go to the emergency department and are sent home that go into higher levels of care for behavioral health. So these provide an opportunity for people to get care in the community and go back home. We've partnered to start a MOORS program, which is a mobile crisis service for children, and an array of other treatment services. For time, I won't go through all of these, but all these services have totaled almost a $40 million investment, over a $40 million investment that Alliance has made into services in this community since 2021 when we arrived on scene. Probably the one thing that is worth highlighting that's big and probably big to this community, I know the county's been a big funder of it well, is the Katie Blessing Center. That's going to be a child, adolescent, probably mega facility. It's going to have a behavioral health urgent care, so 24/7 access to care for people to be seen, assessed. It's going to have inpatient psychiatric beds, and it's going to have some of those residential psychiatric beds for kids who need longer term stay. This will fill a huge need in the community. And so just want to share a little bit on return on investment. And again, we didn't get into kind of what happened after people received the service, but an example, the Steve Smith Center that opened in Mecklenburg, that 24/7 urgent care, 915 Alliance members. So remember, Alliance members are not everyone in Medicaid, they're not all citizens, but 915 of our members were able to get same-day access. If not, those members most likely would have been either picked up by law enforcement, brought by EMS, or gone to emergency department, and they serve anyone in the community who needs care. Additionally, we serve through those teams we talked about, those are served community treatment teams. They're meant to serve the kind of top 1% of people struggling with serious mental illness. 167 individuals, or 162 individuals, excuse me, were able to get that service who previously were unable to. And in its first year of operation, the Mobile Crisis Child Team served 147 youth. Again, there were very limited options for kids besides that. The ED or potentially going to a doctor's appointment, being sent someplace else would have been the option before those services were put in place. Additionally, during the time, and this is one of the things I think we were really proud to have a partnership with the county, there was a really big issue after COVID with children in the foster care system. And I know that's far from resolved. I think the state of North Carolina lost after COVID over 2,000 foster parents to the system. So children were kind of being kept in homes. They were probably having unmet mental health needs all during COVID. And there was kind of explosion. And across the state, particularly in urban areas, kids are showing up in DSS office buildings because there was nowhere for them to go to care. So, I mean, it's just it's an untenable kind of situation. It was slow, but Alliance partnered with the county, and we opened 32 beds within the county specifically to serve those kids. In the last year before the transition to the new Child and Family Specialty Plan, 57 Mecklenburg youth were treated in those beds. Had those beds not been available, these would have been kids sitting in a DSS or a shelter or potentially emergency room. The other thing we did in partnership with the county is, unfortunately, there were times where children couldn't get to a facility. We brought up a service with a provider who would have staff who would go into settings such as DSS offices, emergency shelters, and provide behavioral health stabilization services to keep the kids from escalating further. And there was a question before about Alliance and the dollars we use, and how we spend state dollars. So we talked a little bit about how we spend Medicaid. Alliance spend about $12,500,000 for services for the uninsured, and those are all behavioral health services. For the uninsured, we are not funded to provide services for physical medical care. Of that, there was over 3,000 individuals served, and these services were provided by 43 providers, and there are 28 different services. I think one of the things that we used to share, and we haven't today, is our budget comparison. Our Medicaid budget is probably cresting, or Medicaid is cresting about $2 billion a year is what we spend in services. In state funds, we get less than $100 million to serve the entire population of the seven communities. I'm not going to go through this, but just you'll have this for reference. This talks about some of the services that people get. I think it is worth noting that state-funded, one of the biggest services people receive are treatment for opioid use disorders, and the next is facility-based crisis. And what's interesting about the facility-based crisis, this is all spending that's occurring outside of Mecklenburg County. When your facility-based crisis is here, people won't have to go out of the community, and the spending and the dollars will stay in the community as well. We also get some block grant dollars. That's Mecklenburg service. We spend about $3.25 million on federal block grants. Federal block grants, the state typically gets these dollars from the feds, and they're very prescriptive to the point we'll get the dollars, and they will say this $500,000 has to go to Anuvia, or this $250,000 has to go to Daymark. So we have very little discretion in how those go. There's some historical allocation methodology that the state has developed. So this money comes to us, and we really just pass that directly through to our providers. Providers, you have to meet certain criteria, and one, they have to be nonprofits to be able to deliver block grant dollars. I think that is the end of the formal presentation, and we want to leave ample time for questions. Thank you.
Well, thank you. Thank you both for the presentation. I said this round I was going to start and go right to left. I am going to go out of order because we do, have a commissioner that has to leave. So I'm going to start with Commissioner Powell, then I'm going to come to Commissioner Altman.
Thank you. So with the incidence of autism being 1 in 31 children, I would just like for you to speak more about the families with children that have autism, because you were talking about it earlier. And what category does it go in? And talk again about the financial, because I didn't really understand what you were saying.
I'll start, and Sean can add to that.
Okay.
That's an interesting topic for us, youth with autism. Those majority of kids with Medicaid who have an autism are enrolled with Alliance. We have seen a substantial growth in the number of kids accessing a service called RRBHT, otherwise known as ABA, Applied Behavioral Analysis. That is a major concern for us, major concern for the state, and nationally, the tremendous growth in that service. The state has, over the past few years, have made it less restrictive to access that services. So on one hand, that's great. More kids with autism are receiving the care that they need. The downside is, because of the restrictions, there are providers that have come into our system that I'll characterize as bad actors who are misusing the service and it's put us in a position of having financial issues as well as quality of care issues that we're now trying to reverse. So again, more people are accessing it, good. There's some really good providers in our network. Unfortunately, there's the other side of that, right? It's the 80-20 rule where there's people misusing it. Did I answer your question at all?
Kind of. You know, we get a lot of really intense phone calls from people in need, and some of the most intense are parents with autistic children.
Yep.
And so I just wanted to understand what you were saying, and however we can help get rid of bad actors. It's just, we should not have bad actors in this space, but it helps. Thank you.
Okay. If you have further questions, please let us know. This is a top priority for us, is to make sure that the issues get addressed, but don't throw out the baby with the bathwater, because there are good providers, and this is a much-needed service.
Thank you, and thank you, Mr. Chair, for allowing me to go out of order. I appreciate it.
Absolutely. Absolutely. Commissioner Altman.
Thank you. So it is something that I've seen y'all do, that you vet and confirm that all the providers with whom you are in contract are quality. And so, yes, we want you to be aggressive in ensuring that you are not funding any provider that is not providing a quality service to residents. You know, you said you have $100 million to serve the entire population for one of the buckets of money you were referring to, and that reminds me that, you know, you're sort of engaging in the exercise of population health, and that you're trying to maximize the good. It's not like you just get a set of money for each amount of person. You get a bucket, and then you need to do the most good for the most people, right? And so I'm thinking about Commissioner Griffin, you know, like, I would like to see, I hope you have, and I would think we would really need to see metrics that show wait times. Are they declining? Are they increasing? You know, outcomes, readmission, revolving doors. Like, this is extremely complicated. You did a great job. And yet, I feel I still don't have my arms around how we're doing relative to how we've been. To know, like, are we, you know, are you using these funds to, you know, are you maximizing the good? And I do recognize that perhaps is the job of your Alliance board and not so much us. Nonetheless, I think it would be good for all of us to have insights into, you know, not just inputs, but outcomes, not just inputs and outputs, but outcomes. And how is that improving over time? Like, I would like to know how, you know, I'm glad we've made progress with not having, for example, Mecklenburg County children waiting in DSS offices. Are we down to 0? I mean, I know it fluctuates on a daily basis, but hopefully, you know, we aren't seeing that anymore. Are we not seeing that anymore? And I actually had read about this fraud or misuse of monies for serving youth. I was very surprised to hear you say that you had seen an explosion of supports, because I remember a time when, for example, we could not get certain key partners to do the work because it was too hard.
Right.
So now, you know, Now, to hear there are too many supports, maybe you mean too many supports that are not quality. But can you clarify? Is it the case that we don't have too many high-quality supports? Is it just that we have too many supports that are not quality? Is that correct?
Yeah, let me.
Yes, I'll be
you
quiet.
touched on
Those
a
are some
couple of
thoughts for
things.
you.
I probably forgot a couple of them, but let me make sure I got it. So in terms of wait list, we monitor wait list routinely, daily, right? If somebody calls our member and services line and needs a service, we get them connected immediately to a service. If they have to wait for a service, then we will work with our provider network to expand it. If our provider network, our contracted network can't meet the need, then we'll go outside our network to fill the need. There's a couple areas that we're just going to have issues with right now. One is for dock time. MEC and Wake in our area does much better than the rest of the state by far, but there's still not enough psychiatrists available seeing the Medicaid clients. So we're always looking for Medicaid. So that's one place where you call a wait list. They may have to wait, 60 days as opposed to our desire, 7 to 14 days. The other that we had is related to the kids in DSS. Kids in particular with very severe and complex needs, right? They have behavioral issues, multiple failed placements, family disruptions. Those kids, there's not a lot of places in North Carolina to serve, or not a lot of places in North Carolina that will take those kids. We've always had to pay enhanced rate, pay for additional one-to-one. A lot of those kids are in DSS custody that we're no longer responsible for. They have gone to the Child and Family Specialty Plan operated by Blue Cross, and they went a couple months ago. So DSS kids are not us. So I'm not sure if there's still kids waiting in your office. We think these kids should be with us, but the state made the decision, and so we're supporting Blue Cross and the DSSs any way that we can. And I'm sure you threw in a couple more questions that I got. Did you want to add something?
Just one thing, and I think just as thinking about advocacy, there has been a change. When we first were setting just up the behavioral services, when we were just a behavioral health managed care entity, we credentialed all of our providers. So we got to do all the background checks, all the third-party checks, kind of review for quality measures. When the state went live with full-blown managed care to keep providers from having to apply for like 6 or 7 or 9, 10 insurance companies, the state took over credentialing. And the state struggled. They don't do kind of a full health plan credentialing at this time. So unfortunately, we do have providers who come into our network, and if the state enrolls them in Medicaid, we have no choice but to enroll them in the network. So then we're playing whack-a-mole. We have to come back behind, and it's always easier, right, to set up to make sure something's done right on the front end, then go figure out on the back end it was wrong. So that is a challenge, and I think one of the things we've observed, going back to the commissioner's questions about ABA, you have some providers who do it well, but then you have some providers who are providing such a gross amount of it, it really limits access too. Like if you have kids getting 30 and 40 hours of this a week, you're taking a lot of clinical capacity out of the system, and you're kind of hit a point of diminishing returns. But we have to get those, we have to do a thorough investigation, investigate for abuse, sometimes send up to the state. So unfortunately, our job of kind of monitoring quality became harder. We do it, we've beefed up, we have a lot of staff who do those things, but that is a little bit of a change of how we've had to manage the network, and it just has bearing on, sometimes we get a bad actor in the front door.
Thank you. I just want to urge you to reach out to the psychiatric residency programs and beg them to let more doctors in so that we can have more doctors serving our communities.
Yeah, we agree. We agree. And then Commissioner Allman, I do want to take just a moment to address your other question about, it seems like on one hand we've got greater access, on another hand we're talking about the other side where there's limited access, where ABA services, peer support, some of those services that pay very well, where the needs of the individuals aren't as great as the kids in foster care. Providers will flock to that group, right? They want to serve that group, but this is a group that's lacking. And that's not to be a criticism on providers. The rates from the state's not always the best. These have very severe and complex needs. The risk is high, but we are constantly trying to figure out the balance. Yes, if you want to go serve kids with ABA, we need that, but we also need it over here.
Commissioner Dunlap.
Thank you, Mr. Chair. Thank you for being here. A couple of concerns. And while I don't have information to validate it one way or the other, I think anecdotally, we must be doing something different than we have in the past. I don't hear the concerns that I used to hear. But I still have concern, and before I finish, the last thing I want you to do when I finish is to take us through a person coming to one of us asking us, what can we do to ensure that their child receives services? We need to know what to say to them. Since we went to the tailored plan, we're sticking with the tailored plan. Somebody else provides services for the standard plan, correct?
Let me see if I can make this simple. There's two types of health plans in North Carolina. There's in Mecklenburg across the state. Standard plan, about 85% of the Medicaid population. The best way to distinguish them from the tailored plan is they're responsible for people with low or moderate mental health needs, meaning they're not receiving mental health treatment or they're receiving basic outpatient. If you come in and out of crisis, in and out of the ED, inpatient treatment, cycle in and out of the courts, DSS, wherever it is, those are our folks. That makes up about 10% of the population of Mecklenburg County would be enrolled with us. Does that help?
Yeah. Okay. So I support what Commissioner Altman said about making sure that bad actors are not a part of the program. We've had a bad example of that just in the last year where people have been taken advantage of, and I'd like to see a greater support in that regard. I want you to talk to us about our board member appointments and what the concern is there. I've heard some concerns that they weren't accepted. I'd like to know more about that. The bed count, whether there's still a need for additional beds in Mecklenburg County, and the last thing is, what, if any, action are you taking against those people who have violated trust?
All right, I'll take the board. So first off, let me say, I have found it as CEO for it to be invaluable to have leadership from Mecklenburg County and all of our counties on our board. We have Commissioner Griffin now, we have Commissioner Altman. Does that mean me?
No. It's not for you. No.
All right, well, this is a tough question. If you wanted me to stop, I could. No,
He'd be more than happy to stop.
and then we've had Dina, and then we had Anthony Troutman on our board. That's been invaluable. We serve the most difficult populations in your community. I would rather them be part of the process, understand what we're doing to try and treat the population that's needed, instead of you all hearing it from the community without any context, without any background. So for me, it's been great, and we have that in different parts. What is different from when we do have commissioners, that is certainly under the contract. What has been different is when Dina Diorio and, of course, Anthony were on our board. When we took over care here, we were not a Taylor plan, right? And so they were part of the board. You decided to appoint them, and they served. What changed is in 2024 when we became a Taylor plan. Under a Taylor plan, we took on responsibility for physical health management. What that means is we then contracted with public health. Public health then is a provider of ours. We cannot, according to statute, our contract, have members of our board who are a provider. Public health is a provider that we contracted. So that's the change. I've gone back to my board, talked about how invaluable it's been to have county leadership on our board. We're going to meet with several county leaders to talk about what our options are. But that's the decision. That may be what you're referring to and how we got here.
Well, I look forward to that being resolved.
All right.
So let me add, thank you. The hospital question is a good one. As a state, North Carolina ranks pretty low. There's kind of different equations about the number of beds you should have for population. North Carolina is always like in the bottom, like 10 states. And the problem is what you have in urban areas is you may have enough beds for Mecklenburg. The problem is in any given day, you've got people from all over the state in your hospital. It's a similar issue. We've to 43 to 65 for some individuals. So I think it's a really complex question. I think why the state hospitals aren't sufficiently staffed and why the state is lacking in beds, my fear would be Mecklenburg, you could say, we're going to invest, $100 million to build our own hospital, and unless you could figure out how to keep everyone else out, you'd have the same issue of people flooding to the area where there's largest number of resources. So I think what we try to do is recommend alternatives, which is why we were really excited when the state and the county and Alliance could come together to build the adult facility-based crisis. It provides another option that's outside of a hospital that gives everyone a little bit more control because there's not an emergency room, typical emergency room attached where anyone can just kind of show up or people can be dropped off. So there's more control in those environments. That's why we want to extend urgent care. So making up for where it would be really difficult for one community to just build a hospital. And unfortunately, in the world of healthcare, psychiatric hospital beds are like the lowest reimbursing beds of any other type of bed. When you go into a typical hospital, think of all the things they do to you. When you go to a psych unit, you're not getting all that stuff. So there's the daily rate, maybe some doctor services, and that's it. They're not big money winners. It's very hard to get systems to build those beds until the pressure they feel on their own EDs gets to be such that they need to do it, or they bring in different funding partners. So sorry, it's not an easy answer.
Commissioner Meyer.
Thank you. Thank you so much for being here. And I just want to say, Commissioner Dunlap said he remembers all the problems before, and I was not on the board then, and I was on the board when we voted for Alliance. But I remember seeing it in the news, and I've not seen that at all since we've been with Alliance, so thank you. Couple of things. How many counties do you serve, and which counties are they? I cannot remember. And also, you said when we expanded Medicaid, it was a game changer. And so things are changing now at the federal level. It's coming down to us. How are you bracing for that, and what are the changes that you see coming?
Yes, excellent question. So the 7 counties, I got to see if I can remember them here. Johnston, Cumberland, Harnett, Wake, Orange, Durham, and Mecklenburg.
So Mecklenburg, would you say is the biggest needs? Oh, I see.
Is what?
Do we have
It's the favorite? Yes, of course.
Why did I say favorite?
Is that not your question?
Favorite. Do we have more needs? Do you see as a big county? I mean, I know we have Wake. They're just different, or are they similar?
I think by population, just the sheer size makes them bigger. And I think you also have some of the complexities that you get in urban situations. There's obviously much difference in homelessness and kind of getting people into care. It's one of the reasons we partner with Atrium to start the street psychiatry program that brings together a doctor, a nurse, and then individuals for, I think, Roof Above and Hearts of the Invisible who do care management, go out into the streets and actually provide mental health treatment to people they encounter who are homeless in the hopes of getting them in. Those are kind of services you wouldn't put other places. The good side is you have more professionals. The bad side is those professionals have lots of access to other better funders than Medicaid. But I think we are fortunate to have, for Medicaid network, a really good-sized network here. And again, there's always will be accessibility issues, but I think the numbers are there at least.
Yeah. Can I answer that too? Because that's a question I get a lot, particularly from smaller counties. It's always, is Mecklenburg getting all our money?
Right.
So we get that, I get that question a lot. So how our board treats the populations that we serve, it's individualized. When our board comes to the table, you are not necessarily representing your county or what county you live in. You are coming responsible for everybody's care. The way the managed care company works, it's an entitlement. So no matter where you live in our 7-county region, if you have a medical need or a behavioral health need, we are required to authorize and pay for that service, right? So that's different. We don't just give half the money to Mac and just a little bit to Harnett because they're so much smaller. If Harnett person needs care, we are responsible for caring for that. So we look at every person on an individual basis because that's how the system is structured. Does that make sense?
Yes, absolutely.
Yes. And so of course Mac gets more money, Wake gets more money than the smaller counties, but we don't look at it that way. It's all of our population across the 7 counties.
Can you answer my Medicaid expansion
please.
question?
Oh, yes. Medicaid expansion. I am highly worried about Medicaid expansion and whether or not the state, through the feds, is going to lose expansion. That is a real possibility. You know, a couple things that we're doing. One is advocacy, talking about the impact to the people, particularly our population, who have the greatest needs, now have a benefit. They can't lose that. The other piece that we're looking at is making sure they don't take any of our state dollars. There are folks that are saying, with Medicaid expansion, why do you need all these state dollars to serve the uninsured? We are advocating strongly, please don't, in case this bad thing happens over here, we'll still have a source of revenue. The other thing that I would say, and I hope I'm not going to complicate this any more than it has to be, a lot of the folks we're talking about are Medicaid expansion. We have some, but we don't have a great number of folks with Medicaid expansion in our roles because usually they're working. They don't have their tremendous needs that the traditional blind and disabled group has. They have minimal needs, so we've got a small group. But it's enough that we don't want them to lose what they have. Does that help?
Yeah. If I just one thing to add. The other thing is you saw before that we have these care management agencies, so all the people in the tailored plan get care management. We've done a lot of work to make sure we can get key data to those entities so they know. So that's one of the things we're working on. Like we let them know when they're in the hospital. We let them know if prescriptions aren't being filled. We let them know how they're doing on like their readmission rates. The thing we're working on now is making sure they know when that Medicaid redetermination date will be. Because we don't know the state process yet for that, but we assume we're going to have to be really assertive in making sure people know and get our people either in front of a computer or to a Medicaid office. So luckily we have through that care management, we have an arm that actually the standard plans don't have to help get our population to continue to reimburse. And we're looking like everyone else at AI tools, things that can even be automated callers, textures, reminders, just kind of flood information that if you pay attention, nothing else this year, please make sure you hit this date.
Thank you very much.
All right, colleagues, before I go to Commissioner Rodriguez-McDowell, I just want to just do a time check. It is 4:30. We have 5 other commissioners to go. I'm going to definitely give some leeway because I know this is really important. But I did want to just remind everyone that we did have commissioner reports on the agenda as well. So it's not to diminish the time. I'm going to allow for the time because this is important. I'm just giving a time check. Thank you. Mr. Rodriguez-McDowell.
Thank you, Mr. Chairman. Are you looking for a motion to
No, I'm not looking for a motion right now. I'm just putting it at the top of our minds. We still have 30 minutes, but we have 5 commissioners to go, including yourself.
Okay.
No, we don't need a motion right now. Okay. No, I'm not going to take it right now. We'll go through and finish, but just putting it in the atmosphere in everybody's mind.
Okay, thank you.
Well received. Thank you, sir.
I appreciate you all being here. As others have expressed, I appreciate that we're not hearing the problems that we used to be hearing. But I really do think this presentation would be more powerful if we could see progress as opposed to just giving us these numbers, because these numbers don't really tell a story to us around, you know, how things are better. It's like, this is how it is, you know? So we need to see kind of the movement so that we can have a better idea that we're headed in the right direction. One thing that really concerns me is the, on page 6, you guys are showing that we have 0, and I've heard this through district court judges are telling me this, that we have 0 adolescent substance use disorder beds. Is that something that you guys are focused on fixing, or whose job is it to kind of, you know, bring that number up? Is there anything that the county can do to attract the providers that we need? I would like to know that. And also, you know, this is just another area where our state puts us, you know, in the bottom 10 of all in the country, right? So do you guys actively lobby the state? Do you need us to lobby more, you know, on our legislative agenda? What is your relationship with the state in that? Do you see any hope on the horizon that things, you know, I mean, I feel pretty hopeless, but I just wondered if you guys have the same view. And I appreciate Commissioner Dunlap asking about our board member choices, and I didn't quite understand your answer to that, in that I know it sounded like you're saying we had Griffin and Altman on there. I assume they're still there, but Diorio and Trotman, since they're no longer with the county, are they off? Who's on? What's, can you, I don't know the full story there.
You got it.
No, just me.
All right, let me start with the board question again. All right, so when we've always had MEC commissioners on our board since we took over in 2021. At the start of 2021, one of the things that I've heard from this county is that you wanted county leadership. So you appointed Dina and Anthony to the board. At that time, we were an LME MCO. We were not doing fully integrated care.
I got that.
You got all that.
Fast
All right,
forward,
so
fast forward.
Fast forward. So when we became a Taylor plan in 2024, we then had to contract with physical health. Before it was just behavioral health.
Got that.
Got
Fast
that.
forward.
Contracted with public health, right?
Right.
They are a provider, and they report up to the county manager's office. So,
Right.
so the request for county management leadership on our board is a prohibited conflict because they oversee public health. They are considered a provider.
So that means that you don't allow county quote-unquote leadership, but that doesn't mean that doesn't mean that's like executive leadership versus commissioner leadership, or does that include commissioner
It
leadership?
does not include commissioner leadership. Commissioner
can't have
leadership is
commissioners.
required by statute.
Okay.
In this case, and this only applies to Mecklenburg, the way you're set up, like Wake, for example, they have a public health board, right? Their own board. In Cumberland, they got their own board, right? In Mecklenburg, the public health board reports up to the county manager's office, who signs the contracts, which makes them a provider, right? Just like Atrium is, just like Novant is. They are providers. They cannot serve on the Alliance board. So what we're trying to figure out is if there's a compromise so that if the Mecklenburg County wants county leadership on our board, how do we make that happen, if we can make that happen? And that's my interest, is to figure out how to make that happen.
So, Rob, let me interrupt real
Yes,
quick.
sir.
So just to clarify, just so the whole board is aware, Commissioner Griffin is our appointee to that board. We have talked, the manager and I and staff have talked to Rob and his team. We feel that it's a priority to have our leadership that is represented on the board in the same way that it's been done in years past. So what he is referencing is I will be going to a meeting with their board to make sure that they're clear on what our expectation is, because we're going to make sure that the representation, the expert representation that we have, is clearly in that room, and so we need to talk about that, and give me 1 second, Commissioner. We need to talk about that and find a way, to Rob's point, and thank you, Rob, to make that happen. But that's the position that we're taking. In the past, as you all know, Dina and Anthony were on there, and we'd like Dr. Campbell, whoever the manager deems fit, to participate.
So does that mean we have holes right now?
Yeah. I think it is.
We have a
I think
vacancy.
it's fair to say that there is a hole, yeah, and that's a concern for us, and we met, I want to say last week or 2 weeks ago or something like that, to come up with this path forward. Commissioner Griffin was there, their leadership team, and so the next step now is going to be, I'll be going to the board with the manager and some other folks to make sure that everybody's on the same page so we can move forward.
Thank you.
Yeah. So I just wanted to clarify from our side.
Okay, thank you.
Sure.
Do you want me to get to your other questions real quick?
Other questions, please.
All right, the other one on the progress on data, great question. We tried to sort through the big, so we used to, when we presented here in the past, after we first started, there was 2 numbers we were looking at: increase in access and increase in the number of providers in our network. That was 2 things that I heard from this board was important to them. We did that. What's changed is we became a tailored plan, took on physical health. So it's difficult to compare apples to apples because the whole system has changed for us. But in the past, yes, we have what has been better is more people served and more people, more providers in the network. What, in terms of data, what you'll see upcoming is what's called HEDIS measures. There are specific measures or metrics that will be held accountable to that demonstrate are people actually getting better. And we are responsible for that, I think, in a year or so, and we will bring that data back to demonstrate that amongst other outcome data.
Thank you, that's great. The substance use,
I'll let Sean handle
child,
that.
adolescent substance use disorder beds.
Interestingly, as much as you've heard, like that's a big issue. It's only been recently bubbling up. I've always been surprised when we look at our data how few youth come into services for substance use disorders. I think there's a lot of reasons. I think it's probably underdiagnosed. I think still, with kids, there's still more kids have insurance and aren't in the Medicaid system. A lot of kids sometimes get to it after they've been in residential. We've historically, it's not ideal, but we've been able to get kids into the PORT program, and there used to be a state program, which I can't recall. I think it's a challenge, it's a need. We've been working closely with the judges on gaps, and the problem is there's not a big enough need in Mecklenburg for us to have a provider come in and build a facility or where it would make sense for us to fund the build out of a facility. This is the one, maybe not the one flaw, that's probably being very generous. One of the flaws in the state model where now you have, in the Medicaid world, 10 different groups responsible for Medicaid care at some level or not. And so if we need this service, if we build it in Mecklenburg, there's nothing we could really, not a lot we could do to keep other kids with Medicaid coming to it. So we would, if we were to do this, we'd have to figure out how to partner with the state and the other health plans so that either the county doesn't pay for something that other people use, or Alliance is not paying for something that we have a need for, but we have 3 beds filled at any given time and the rest of the state is filling it up. So it's a challenge with Medicaid. With the uninsured, you can kind of do some more things to box in your geography. With Medicaid, because it's an entitlement, we can't tell a Medicaid provider you can't contract with to take kids from a different county. So I think it's just something we need to. It hasn't been on our radar historically with the state. I think it will be as we continue. We've been having some of these conversations on the crisis side of things as well.
All right, thank you. This is super important to me. Just want to flag that.
Yeah, absolutely. I think, that's why we wanted to tee it up for sure.
Commissioner, did you want me to answer your question about lobby work? I can do it quick.
Real quick, Rob.
I'll do it real quick. Yes, we have a government relations and lobbyist team. We are constantly trying to make changes for the better for the people that we serve and our providers. People with mental health are not down to General Assembly advocating. We're the only source of truth for that population, and we are constantly trying to fight policy changes or issues that impact member care and our providers delivering the care.
Thank you.
Commissioner Townsend Ingram.
Thank you for being here, and I'll begin by just saying all of my questions, I want to be able to reserve the right to have them, like maybe put them in an email or something like that, because we're not going to have time to go over it. Had lots of, and I started last night trying to understand the information and synthesize, and it speaks to what everybody else, all of the other commissioners had said about putting it in a language and putting comparisons there so that we can have a clear understanding and tell a story, so that you can tell the story of what's going on. Because I had the same question about the no adolescent beds. I had to stop and say, what is SUD? And me and Elaine figured out there was another acronym there, but substance use disorder. So having those things to be able, to tell us what we need to know based on the questions. I feel like we've been here before. Like, these are questions that we've had before, and so can you put them in a way, kind of anticipate a little bit? And I know that this, we're lay people, so we don't understand, but if you could get that. Some of the questions that I have, for instance, you talked about you deal with the most severe individuals. Where are the ones that aren't severe? Where do they go? Who are they referred to? I already addressed that with the no adolescent beds. And with regard to the referral and the no active beds, how do you get your referrals for children so that there are beds? Is that through just the social justice system? Is it through the foster care, or do you have any relationships with the schools and the school systems and things of that nature? I think for now, I'll just put and is there a dashboard somewhere where we can really kind of look at this information? Because like I said, I feel like we've been here before. We've asked it, maybe not of you specifically, but we keep asking the same questions over and over again and not getting the data and the information that we need so that we can come up with solutions to help, or at least contribute.
Yeah. And I appreciate that. I'll be honest, I don't get a lot of counties always wanting to step up and say, we'd like to help, what can we do to help, and trying to negotiate that. I can answer a couple of these real quick. So one of your questions, where do the non-severe people go? So there's a couple of places, right? People with commercial go back to their commercial plan. People with Medicaid who are non-urgent or have mild to moderate are within the standard plan. They're responsible for connecting them to service. The uninsured, underinsured are with us. So again, we're just one small cog in the wheel of healthcare, but our group is those with the greatest needs. The other question, referrals, we'll send over a one-pager. I think I sent it to Commissioner Griffin. We tried to simplify it as best they can, but we have a 24/7 call line. Anybody can call. You'll get a live person, and they will help answer your question. You can walk into a provider agency, and you can get care that way. We get a lot of referrals from community stakeholders who know how to access care. When I get this question, I got this question once from a member. I was on the golf course, and one of the members didn't know how to access care, and I kind of got yelled at. And we don't serve golf country club member people, right? We're serve people with Medicaid and the uninsured. We do a lot to make sure that the referral sources, the court system, DSSs, homeless shelters, all those places know how to access care, and they're pretty good. We get tens of thousands of calls every month trying to help people get the care that they need. Does that help? Yeah?
Some, but CMS, I would love to know.
Love to sit down with you and talk through some more of that.
Commissioner Griffin.
I'll try to go real quickly. When I joined the board about a month or two later, I actually called the line about 9 o'clock at night to try to figure out how to get help. And they actually responded in terms of what providers by asking me, what's my residence, what county am I living in, what's my address, in terms of trying to connect me to a provider. So that was really helpful from my perspective to try to figure out where to go. Two quick questions. Looking at the opioid and your substance abuse disorder, it looks like about, and help me if I'm reading this incorrectly, about 1,200 residents of Mecklenburg County receive some type of services, either state funds or Medicaid funds. That just seems to be real low for Mecklenburg County. I don't know if I'm looking at this correctly, if that's a different category. That's one question. The second question, sort of following up, Commissioner Townsend Ingram, we always hear, there's a need for mental health services. I don't know how to respond to that in turn, but you shared some information about the standard plan in terms of low and mild, and I'm not a clinician, so I don't know how to distinguish between low and mild. But how to respond to the public when they say we need more mental health. Is that because of a lack of providers, or for folk who are on Medicaid, which is about 375 people here in Mecklenburg County? What's causing that question to constantly be on the table in front of us? Two quick, easy questions for you.
I'll start with the substance abuse. So I think part of it is there's certain ways, and probably need to refine the data on this. There's 2,000 people roughly, if you look at the first chart is Medicaid. So those are people who had Medicaid, who got a substance use disorder service. And then there's another 1,000 who are uninsured. There are certain services that actually get qualified in a pharmacy expense and medical expense. So let me just do a better job of pulling that out. This was kind of a quicker blush, but I know like for opioid treatment, for example, oftentimes if someone's on outpatient substance use treatment where they just go to their doctor and get a drug called Suboxone, they don't go to a substance use provider for that. They go to their primary care. There's a prescription. We fill that. I should have included that in those numbers, and that's just my fault. I think that would greatly escalate because that is one of the prime things people get now is medication-assisted treatment.
All right. Thank you.
The second question, I'll let Rob start, and then I'll jump in afterwards to help. What was the question? About people asking for more.
I mean, people constantly ask, and make comments about mental health. We need mental health. And we have like 375 residents in Mecklenburg County. I think last count was on Medicaid, somewhere between 375 and 400,000. So the question is, are we talking about mild, low, or moderate? How do we respond to that?
Yeah. Again, that question comes up all the time. The system, quite frankly, is a little bit more complex than it used to be. In the old days when we were LMEs and community mental health center, you had a mental health or substance use need, you came to the community mental health center or to the LME in that catchment area. Now there's 9 health plans. So if you have Medicaid, you need to look at your health card and it'll say where you go to get treatment, right? Just like any insurance card, it'll be on that, right? We also know that people with Medicaid will lose the card or still not ready to access that card. And then you have people that's got insurance, right? They need to access their insurance. We try with our group, those with the greatest needs, we educate. We have care managers who check on them to make sure they know how to access the care. And then we work with our providers to make sure that they educate. I wish I had a simple answer, and there's one sentence that could answer all that question. The best answer I can give is to call us, the 1-800 number. We should have put it on there. Our team will help them get connected to where they need to go.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you, Commissioner Leek.
Thank you. Let me first say thank you for your presentation and all of the information. When you talk about mental health and mental incapacity of our people, how do we respond with support from the county? It's a grave issue, major issue, because what I may perceive to be healthy, someone else may say this person has a mental problem.
Mm-hmm.
How do we address this as county commissioners, persons even with drug abuse?
Yep.
How do we respond as we ought to? And my second question deals specifically with the amount of money for 25. Will this increase, this $3,025,000 increase for 26?
Yes, in responding to the county, I would, let me make a broad statement. I would treat anybody in this county that has a mental health or substance use need like you would treat anyone with a physical health need. Mental health and substance use is a health care need. If you need care, the simplest answer is you can call us or they can go to a provider, and that provider will then link them to us for
the
services.
resources.
Just like physical health, right? Refer them to a cardiologist or a primary care physician, refer them to a behavioral health issue. On our website is thousands of providers.
So you're saying the money will go up next year, for this year?
The money will go up?
Yes, I asked.
God willing, if we're hoping the money always goes up, right? Mental health is always
That's not what you hope,
underfunded.
I'm
We're
saying.
ranked 46th in the country, and with one of the best economies in the world, and we're ranked like 46th. I think we're up to 44th in the country on funding for mental health treatment.
Right. Why must it pass through the state? Why can't it come directly from the federal government?
That's probably a genius question that I don't have a good answer for, because that's the way it's always been, right? The money flows down. Of the 100%, 66, for every dollar spent, 66 cents comes from the feds. The 33% comes from the state government. So the state funnels it down, gives it to the state to manage, then the state gives it to us to manage, and then we contract with providers to deliver the care.
Based on what you receive?
Based on what we received. Now, again, I want to reiterate this again. We are managed care. We are at risk. If somebody meets medical necessity and needs that service, we are obligated to authorize and pay for that care, right? So that's why all the policies, all the procedures, all the rules line up so that we can do that.
Yeah, I think there's just, the one difference is Medicaid and there's non-Medicaid. And the non-Medicaid just gets handled differently. Like Rob said, Medicaid's entitlement, we have to cover everyone. With the block grant dollars, it can be for a specific project, it could be for a specific population. So that's the difference. That's that smaller amount of dollars you're talking about. And those dollars actually are at risk. You probably heard this last year. The government overnight cut funds and they turned it back on the next day. Then they did it again later and turned on some of it. So the block grants they're at risk a little bit.
And
Mr.
we're
Chair.
living in a violent society today. Remember that. That's part of it also. Thank you, Mr. Chairman.
Mr. Chair, I just want to underscore Robert's response to one of Commissioner Leake's question regarding responsibilities, because oftentimes there's a perception that counties in North Carolina are responsible for funding mental health. And as he clearly outlined, that funding, primarily 66%, I believe it is provided by the federal government, and another 33% or so, 34%, is provided by the state. In terms of the services that we do provide, we categorize those as we call gap services, just try to fill in between. But when it comes to the core responsibility and where those dollars lay, as he noted, it's with the federal and state government. I just want to make sure that that point was not missed.
Yeah, well
Thank you,
said.
Mr. Chairman.
Thank you for that. Let's do two things real quick. One, let me get a motion for us to extend, please.
So moved.
How long?
Do we have to have a time certain, Mr. Attorney? Okay. Can I get a motion to go to 5:15?
So moved.
Moved and seconded. All those in favor say aye.
Aye.
Any opposed? All right, that's unanimous. What I would like us to do is, before I go to my comments, Commissioner Dunlap had a great question with respect to what it looks like when someone calls. If you could just give us a step process, high level, and to answer his question, please.
Sure. When someone calls, they'll get a kind of what we call a member service rep. They do a quick screening. If they're not in any danger and need referral, they'll look to see if they're covered by Alliance or if they're eligible for any Alliance services. refer them to that provider. And sometimes it's a warm transfer, sometimes we can make an appointment electronically. If it's not one of our members, if they have commercial insurance and we can see that in our system, we refer them to their provider, say, hey, you've got to call Blue Cross Blue Shield, or here's how you get Blue Cross Blue Shield's directory, because we don't know the coverage they actually have if it's not. But anyone who calls us who doesn't have coverage or is covered by us, we make sure they get an appointment either scheduled or warm transferred to a provider who can take the appointment. If they're in a crisis, we send out a crisis team, or we arrange for them to get to a crisis facility, so people don't go without a need met. There are some folks that we just can't give an answer to, but we actually will follow up, and our actual staff will actually contact the insurance company and say, hey, your member called us on this date with this information, and we transfer that information so that insurance company can carry back up with the person. Unfortunately, we don't have always visibility to know if a provider in our network takes Aetna or Cigna, or in this, like even Blue Cross has 5 or 6 different plans that some providers only participate in 1, 2. So it's complex, but if someone's not safe, no matter what their insurance status is, they get referred for a crisis service, and we'll make sure they get there. And if we call the police, we make sure the police are able to pick them up and bring them there. If we have a mobile crisis team go out, we call to make sure that happens. If the person says, I have a family member who can take me to a crisis facility, we call the family member and the crisis facility to make sure they got where they needed to go, and that's regardless of insurance coverage.
Is that helpful? Okay. All right. Let me just say thank you for being here. I certainly, during the retreat, I certainly requested that we get some more information as a board and as a community with respect to the impact of Alliance. Personally, I was very hazy on what we were doing and what was happening in the community. So this has been helpful, and I actually had the benefit of another meeting where I was able to learn a lot more. One of the big misconceptions, I think, that's throughout the community, and it's a conflation, I believe, and keep me honest here. There's this idea in the community that Mecklenburg County is responsible for the delivery of mental health services, right? Like countywide, this is what we do, almost to the extent of no matter where someone is on the socioeconomic spectrum, this is a county function. I think the second conflation that we really have to clear up, and I think most people are very hazy, is that we are a service deliverer, right? So when I say we, I mean Mecklenburg County. Like, you're going to walk into, we have this physical location, and we shuttle people in and out, and we're delivering treatment and so on and so forth. And so I appreciate the clarification with respect to providers and a provider network, right? Experts that are in the community-based, that receive credentialing from an entity, or they become in network with insurers to be able to deliver, bill, and be paid for that level of service delivery. I think another thing that's important for people to understand, different providers deliver different services. And so that is another disconnect with the people that we have touch points with as well. And the final piece that I would say is, as it relates to Alliance and the relationship with Mecklenburg County, one, it's statutory. We're required to have a relationship in the way that we do it, right? But you all are dealing with a subset of the community. So when we're looking at the numbers, right, a lot of people say, well, you only did whatever, right, or this. I think we have to really start pointing out that within that subset, we have to be able to quantify a little bit more what that means, right? If I'm looking at 3,400 clinicians, or let's go with mental health, 257 entities or whatever. If in my mind, I'm juxtaposing that off of 1.1 million people, right, and not the actual subset, my scope, my perception is completely different. So I guess what I'm going to commit to do is working with you all so that we have a better understanding of the subset that the county is responsible for through the Alliance Network. Because I think that is a big disconnect, and when we're out in the community, we're using these broad strokes, these big, we're not really educating the community in the way that they need to understand what our scope of responsibility actually is.
That's definitely true.
So I would like to, Mr. Manager and Dr. Campbell, really get with Rob and team, and if I have to clean up where I'm trying to go with that, but I just really think that we have to do a much better job of educating, because there are people that think that we're responsible for connecting them to services, and they're not in that subset that we are responsible for through your network. So that'll be a takeaway. And so again, I'll leave it there, but want to just say thank you all. This was a great conversation, and we need to have a more regular cadence on this, okay?
Good. Thank you.
All right, thank you.
Thank you, gentlemen. Mr. Chair, that concludes the items that we have on the agenda.
Okay, all right, we're going to move to commissioner reports, and, Madam Clerk, just set the timer. Who does have reports today? No reports? No one has reports? Okay.
Second.
Moved and seconded to adjourn. All those in favor say aye.
Aye.
Opposed? Ayes have it. Meeting adjourned. Thank you.
Meeting.